Please note, the opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of Tri-County Orthopedics. Any medical advice or treatment recommendations discussed should always be reviewed with your own healthcare provider. This podcast is not a substitute for professional medical advice, diagnosis, or treatment.
Welcome back to the OrthoZone podcast of Tri-County Orthopedics. My name is Dr. Paul Lombardi. I'm the president of Tri-County Orthopedics and one of the joint replacement specialists here at Tri-County. Today I have the wonderful pleasure of welcoming Dr. Claudia Ginsberg to our studio about the topic, how do you know if you're ready for a knee replacement? Welcome, Dr. Ginsberg.
Hi, Dr. Lombardi. How's it going?
Not too bad. Good to see you today, as always.
Thank you for having me.
Before we get into today's topic, could you please tell the audience a little bit about how you chose to go into medicine, where did you do your residency and fellowship, and how you ended up here at Tri-County?
Sure. Let's see. I graduated medical school in 1999, and then I did a residency in general internal medicine for 3 years. But somehow, I don't know, I felt like I was just manipulating medications and numbers, and I really liked the hands-on aspect of musculoskeletal medicine. So I ended up pivoting and then going to do a sports medicine fellowship at Pittsburgh. And then when I finished that, I then came to work at Tri-County Orthopedics as the first non-operative physician here. And that was in 2003, and I've been here ever since.
That's right. You've been here for over 20 years, Claudia, and it's been great to have you. And we've become good friends, and you've taken care of so many of our patients, and we're very grateful. So your role here at Tri-County, maybe describe as a non-operative orthopedist what it is that you do on a day-to-day basis.
So I see patients for a wide variety of musculoskeletal issues, probably most commonly knees, shoulders, and hips, but a little bit of everything. And I take care of some sports teams. So I have, teenagers, and I take care of middle-aged weekend warriors and older patients with arthritis. I really see the whole gamut. I mean, really in a day, I could see a 12-year-old and a 92-year-old, and for me, that's variety, that's what I call variety, but a lot of different musculoskeletal issues. Yeah.
And you're the team physician for several high schools in the area, correct?
Yep. Roxbury High School, Morristown Beard School, Morris Hills High School, and then I help out with Del Barton and a few other schools, whatever needs, if they need somebody.
So our topic today is, how do you know if you're ready for a knee replacement? So I know, Claudia, you see many of these patients, and so how do you start? When a patient comes to you for the first time and you diagnose them with knee arthritis, what is the discussion that you have with these patients?
So I think the first thing I try to make clear when a patient is diagnosed with knee arthritis is that there are a lot of treatment options, and it starts, sort of the three pillars that it starts with are keeping your weight down, keeping the muscles around the legs strong, and wearing good shoe wear with good cushioning. And that's true for prevention. I get a lot of questions about prevention, and that's true for once you've been diagnosed with arthritis, that those are like the three kind of most important things that you can do to start out with. And then after that, we talk about topical creams, oral medications, and various injections.
So things like Voltaren Gel and Salonpas and things like that?
Right. Topical creams, they've really come into vogue in the last couple of years. Voltaren Gel came out it was prescription for a while, and then when it came out as being over-the-counter, very widely used on knees. It can't penetrate that deeply, but my patients will tell me that for like an hour, it'll definitely help their symptoms.
Yeah, I totally agree.
So that can be very useful. But when that falls short, people are using a lot of Tylenol and Advil or Aleve. And, oral medicines, it's never good to be married to an oral medication. They're definitely helpful, but the oral medicines, especially Advil and Aleve, they raise blood pressure, they can bother the stomach, taken long enough they can slow down the kidneys. So there's just a lot of side effects, and they're not intended for long-term use. So strategically, patients use them to their advantage, but then some patients are using them altogether too much and too frequently.
So particularly anti-inflammatories like Advil or Motrin or Aleve or Naproxen, medicines of those sorts, focus for us the troubles that older patients in particular could get into if they're taking anti-inflammatories.
So if you look at the black box warnings on even something as simple as Advil or Aleve, which is ibuprofen and naproxen, it says right on there, heart attack and death. They don't make any bones about it. It's right on there. Most people don't take the time to read that stuff. But yes, because it raises the blood pressure and it can help patients retain water, certainly can eat a hole in the lining of your stomach, slow down the kidneys. Those are some big ticket items. And some people will take it for years and never have those issues. But there are some people that will take it for just a few weeks and have a lot of trouble with multiple of those issues. So you don't know who's who, but these are also some of the most widely used medicines in the world.
So there's also a debate regarding patients who take blood thinners that then may have to take an anti-inflammatory. So anti-inflammatories do have an effect on platelets, and they decrease platelet function. So we get into this debate whether or not the medication Celebrex, which does not affect platelet function, is that something you could take with blood thinners, in your opinion?
If you're on blood thinners, you're first reaching for Tylenol, there's no doubt. But there are times when a person needs an anti-inflammatory by mouth, and Celebrex is touted as having probably the best side effect profile if you're on a blood thinner, but even then, you want to take it for the shortest amount of time possible. And I have certain patients where their cardiologists have told them that they could be on it for extended periods of time. But, you know, the longer you take it, you're going to run into some issues with something at some point. So it's not really recommended.
So at this point, the patients have tried losing weight and
physical therapy. I always recommend physical therapy. Every study about knee arthritis says that patients will do better if they have a guided exercise program.
Physical therapy and perhaps some anti-inflammatories, maybe some Tylenol. So now they're at the point where, okay, those things haven't worked. What's the next stage for these patients?
So then we talk about injections. Injections come in two flavors, cortisone shots and gel injections, otherwise known as viscosupplementation. People will probably try both of those at some point. And some patients swear by one, some patients swear by another. They're different. You know, cortisone shots are more like liquid Advil. You put it directly into the knee via a needle, and it takes effect within maybe 2 or 3 days, and it can last anywhere from, 6 weeks to 6 months in probably 70% of patients plus, right? The gel injections are a more natural product, so people like that. Think of it like egg whites. It's a very thick, viscous jelly that you can put into a knee, and it kind of coats the lining of the joint, fills in some nooks and crannies, maybe creates a little bit of a cushion. It probably has some anti-inflammatory effects as well. That takes longer to kick in. That needs to usually be ordered through the insurance company if it's private insurance, but that is covered by most insurances twice a year.
So in my practice, I tend to usually start with cortisone. Cortisone injections work in everyone. It's a question of how long, whereas I think the data shows that gel injections have about a 50 to 60% success rate compared to a cortisone injection.
And in my experience, I agree with that. I think that's about right. Yeah.
So if you're a diabetic, is there a problem or an effect that a cortisone shot can have on someone's blood sugar?
Oh, that's a good one to bring up. Yeah. So cortisone will, no doubt, it will raise people's blood sugars, even people who aren't necessarily diagnosed as diabetic. They just might not know it because it happens with it. They're not checking. But it will dysregulate your blood sugars and elevate them for usually 2 to 3 days, but sometimes longer, depending on how brittle of a diabetic you are. So sometimes we'll do lower dose injections, or we would favor maybe the gel. But I think since not as many people respond to the gel, we want to give them something they respond to, so we tend to reach for cortisone first. But yeah, the diabetics, you have to be a little cautious on that.
So let's hypothesize that now you've given a patient cortisone, and when, in your opinion, is cortisone no longer effective? Whether it be, should it last for 4 months? Should it last for 6 months? Should it give them 50% relief of their symptoms? What, in your opinion, is the reason to say, okay, I've maximized cortisone therapy?
So if cortisone lasts 6 months or 9 months, and I get plenty of patients where I don't see them again for 6 to 9 months, then I wouldn't change a thing. I would do another cortisone shot when they come back in. But over time, you'll often see that they don't work as well for the multiple injections, and they last for shorter periods of time. And who knows if that's the body getting wise to it, or if that's that the arthritis is actually getting worse. That's sort of hard to say. But if the cortisone shot's lasting less than 3 to 4 months, then let's try something different. Let's think about something else. Maybe that's when now it's time to try a gel. And then some people just really prefer the idea of something natural. And so that's, then it's a gel.
A question a lot of patients have is, can you give someone too much cortisone? Does it affect the cartilage in the knee to a significant degree if you do it too frequently?
I get that question a lot, and there have been some studies that have come out within the last couple of years that look at that topic. But the trouble is, giving someone multiple cortisone injections over a period of time, their knee arthritis is also worsening during that period of time, whether they've had a cortisone shot or not. So it's kind of hard to say whether it really is cortisone or whether it is just the worsening of the arthritis. And the people who are coming in for more cortisone shots are the ones who probably have the worst knee arthritis that's getting worse over time. So to say that the people who have more cortisone shots have more arthritis, well, is that the chicken or the egg? I mean, the reason why you're coming in for that shot is because you have more pain.
Yeah, I completely agree.
So, those studies, I just look at those with a little bit of a grain of salt. But if it's no longer working, then we all agree it's no longer working. We try a gel injection. If you're bone on bone for the gels, I think it's harder. You don't have a scaffold to keep the gel there. So I think it's pretty clear that once you're bone on bone, the gels have a lesser chance of working well for you. But we often still try it because people want to feel like they've tried everything before they're going to have surgery.
I found it interesting when I discovered that the FDA does not consider gel injections a medication.
It's a device. It's seen as a medical device. It's classified, like a cushion in your shoe.
Yeah, it's classified as a medical device because it doesn't have a side effect profile. Back in the day, one of the first ones we gave was Synvisc, and that was an animal protein that was derived from the combs of roosters. Then we discovered there were patients who were getting allergic reactions to the animal protein. But now I believe they're all synthetic, aren't they?
They're not all synthetic.
I learned something today. Thank you, Claudia. Unfortunately, though, a lot of patients don't understand the rules that Medicare puts on doctors' offices regarding gel injections. Can you describe some of that?
Yes. So with cortisone shots, cortisone's cheap. The insurance company doesn't really care how often I give you cortisone. It's more for medical reasons and for realistically.
The reimbursement for cortisone shot is $5.60 for the cortisone medication itself. That's how much Medicare
they pay.
reimburses us, yes.
But the gel injection is an expensive product. And so for the gel injections, the insurance companies, Medicare and private insurance, they will cover it twice a year. Very strict. 6 months and a day. And they just won't pay for it sooner than that. And if you get it from Canada and you come in and you have a doctor give it to you, that resets for another 6 months. It's not like it.
Well, actually, the rules now have changed with respect to Canada. You cannot buy Synvisc from Canada. Otherwise, you'll get a knock on the door from the FBI. That's happened on several doctors' offices where they've actually raided doctors' offices because they bought Synvisc from a foreign country other than the United States.
Wow.
If you could believe that. So actually, the Medicare rules can even be more tricky because if you have straight Medicare with a supplement, we can give you that medication the day of service. If you have a managed care Medicare, like Aetna and United, right? Tell them all about that, Claudia.
Right. So a managed care is technically you have private insurance that you've opted out of government-sponsored Medicare. You have private insurance. And in those cases, like all private insurance, it needs authorization. And so the day you come into the office, we can then contact the insurance company to apply for the gel to see if they will cover it for you. But that'll be longer before that medicine will then be approved and then sent to the office. And then we will call you that it has arrived. So, it's not same day for that.
So, Claudia, while you're doing injection therapies, is physical therapy still indicated?
Absolutely. Keeping the lower extremities strong and flexible is a really key part of treatment, no matter what else you're doing. It is one of the mainstays of treatment, for sure.
So we've gone through cortisone injections, and now we've talked about gel injections. Perhaps, Claudia, could talk about some of the more exotic injections that are out there. Let's start with PRP. What's your opinion about PRP?
So regenerative procedures, which includes PRP injections and stem cells.
PRP is
platelet-rich plasma.
Yes.
So these are regenerative procedures. The concept is that you can get your body to make more of itself. You can stimulate your own healing response to repair and restore and renew the cartilage that you have in your knee. There are a few studies that maybe are promising. It's not covered by insurance because we don't really have great data that says for sure people who have knee arthritis are going to benefit in any way. And benefit at all from these injections. So they're not covered by insurance, but people will pay out of pocket and seek physicians that will do these types of procedures. I think there's a lot of prayer involved. And
I also think there's a lot of very unscrupulous practices that take advantage of people
who are desperate, who really want something.
Who really want something to work. They don't want a knee replacement. And they'll go to a clinic that promises them the moon because they're giving them PRP injections. And my research on this, because I get the same questions you get in your office, is not every PRP injection is the same. Is 2 million platelets the right number? Is it 4 million? Is it 6 million? So that there is a lot of data out there that really hasn't decided yet what exact concentration of platelets is indicated.
Right. And that's why it's hard to compare studies, because they're all using, it's the Wild West. Everyone's doing their own thing. So until there's some standardization of practices where you can really compare apples to apples, it'll be hard to really say conclusively.
And there is, I believe, is a controversial topic when it comes to knee injection, which is, I'm asked all the time, doctor, how come you're not using an ultrasound machine to inject my knee? And what patients don't realize is that Medicare considers the routine use of ultrasound to do a knee injection fraud. There are certainly reasons where an ultrasound would be indicated if someone is morbidly obese or if there is some sort of either congenital or some sort of acquired condition that makes access to the knee difficult. But routine use of ultrasound is considered fraud by Medicare.
Because it's such a basic injection. I mean, if you're an orthopedist and you can't get into a knee, you should be doing something else. Like, it's just so basic that the idea, and we've been doing them for so many years without ever before ultrasound was even a thought, that to add that, there are certain joints where, like a hip, for example, where it's hard to get into a hip, and you're going to want some kind of guidance for a variety of reasons, technical reasons and such. But for a knee, you don't need ultrasound, and if someone charges you extra to have ultrasound done, I just think you're wasting your... Probably should choose a different doctor.
So tell the audience about stem cells.
Stem cells are another one of these regenerative procedures, quote, regenerative. That's the concept. And the concept is great. I absolutely want to believe that we can make things out of a cell that could become anything. But I don't know that at this point in time, anyone could really tell you that if you put stem cells in your knee, that how do I know you're not going to grow a mustache in there? I don't know what you're going to grow in there. I mean, I don't know that you know what exactly you're growing, and that we have that knowledge on how to stimulate which parts of the genes to turn on to make this protein or that. So that's a lot of money. It's like $5,000 for stem cells, and you have people who are famous people who swear by this or that or the other, but those people are also getting lots of other treatments other than the stem cells, and those people are often younger. So, that's hard to compare.
And what I tell patients, I'm sure, Claudia, you could tell them the same exact thing, in that I see multiple numbers of patients with arthritis who need injections every day. So how come I'm not doing these fancy schmancy injections and getting $2,000, $3,000, or $5,000 per shot? Because they don't work, right? And you have to have, that's your job as a physician, is to interpret what treatments patients can benefit from and which ones they shouldn't be considering. And that's part of our role.
Right. And you don't want patients to waste their time or money. I'd rather you took that $5,000, have your knee replaced, and then go to Aruba, have a great time.
So, Claudia, we've arrived at the moment where it's time to consider knee replacement. So I know that in my practice, there's the art and there's the science, right? The science, some of it we've talked about today, whether it be medications or injections or therapy. And then there's the art. When you talk to patients and you listen to them, how are they doing? How are they able to live their lives and their lifestyle? So when do you think it's time for them to walk across the hall and see me for their knee replacement?
So one of the most fascinating things that I find about knees, knee arthritis, orthopedics in general, is how two people can have what looks like the exact same x-ray. And one of them is still playing golf, and the other one is literally on a walker, like limping into your office. And why is that? Because there's so much variability. How much you weigh, how strong your muscles are around that joint, what other joints are bothering you, what exercises you do, what sports do you do, what medicines do you take. I could go on and on about what makes two patients different. So it's just not the same recipe for two people on how they're going to treat their arthritis or when they're going to know when they're ready for knee replacement.
Yeah, I found when it comes to this decision that patients don't want a knee replacement. And I don't blame them, right? Nobody wants a knee replacement. I think they have to take that emotional journey over, well, I don't particularly want one, but it's time because I think I need one. And I think those are the patients that go on to be okay with the decision, because a lot of patients will keep wanting cortisone shots and gel injections, even though you know that what you're doing for them isn't really helping, correct?
Yeah, I think it's scary, right? I mean, when are you just going to wake up one day and say, yes, cut me open, take out what I've got, put in a piece of metal on plastic, and I'm going to like it? So some people are just in general more surgery averse. Some people are more procedure, don't mind procedures. It's just your general profile on anxiety and what you're willing to do to get a better life or to get pain-free living. Some patients will go to great lengths to do everything possible, and they're literally coming into your office limping on a walker before they finally say, okay, I think I need a knee replacement. And then other patients, they go from playing singles tennis to doubles, and they're like, oh, I think I need a knee replacement.
And, something I do at times is I ask the patients to go home and speak to their families, speak to their spouse, because patients don't see themselves the way their loved ones see them from the outside. The loved ones see them struggling with getting in and out of a car or going up and down stairs or not enjoying vacations. And I think all that together, then usually patients wind up making that decision. I know that on my schedule, I will see a patient clear as day that says, patient of CG, Claudia Ginsberg, here for right knee osteoarthritis. I know that patient's coming for...
I've done it all. If I'm sending it to you, then we've discussed it and I've answered their questions.
And the part actually that I find the most disturbing is that 100% of those patients don't want to see me because that means they can't see Dr. Ginsberg anymore because she's so wonderful to them, and it's almost like it's their extended family members when they come to my office.
But I see these people for a long time.
Dr. Lombardi. I want to see Dr. Ginsberg.
So I see patients over many years. I've been here 22 years, so I have patients that I've seen from the beginning, and I've nursed them along, and we've done all kinds of things, and eventually we come to decide together. And I think it's nice to have a little partner in crime to, talk about what's worked and what hasn't worked, and, am I stupid for not considering this, or my friend said this, and, to have someone to bounce those ideas off of. And I really see that as my role as sort of an advocate and sort of, a doctor who's also sort of a friend that you can be honest with about what you've tried and what you need. Yeah. So many patients will say, well, I'm not bone-on-bone arthritis, so I don't need a knee replacement, right? Yeah. And it's important to know that there's no one age at which you have to or can't have a knee replacement. There's no appearance on the x-ray that tells you that you should or shouldn't have a knee replacement. I have some patients that are bone-on-bone that for their needs, they're okay. They're managing okay, and that's what's right for them.
I like to tell patients actually to completely disregard the x-ray, because the x-ray just gives you diagnosis. You have osteoarthritis of your knee. The severity of that depends upon how your lifestyle is affected. Because like you said before, you'll see a patient with barely any changes on x-ray and they're in wheelchairs. Then you have patients who are completely bone on bone and they're running marathons.
Yeah.
Right? So I try to tell patients to take their eyes off of the x-ray screen and rather, we have a conversation, because that's where the answers lie.
Right. The only time that I would say that I use the x-ray is when someone is limping into my office and they are telling me that they're okay. And then I think a picture does say 1,000 words when you say to them, okay, well, take a look at this and let's compare both of your knees. And you can see on this side, you have zero cartilage left. You are bone on bone. That's a very powerful picture to say to some of those people, this is only going to get worse over time. So you're not in any better position health-wise to have a knee replacement at 82 as you are at 80. So if this is the knee that you're okay with, all right, but the writing's on the wall that this is going to get worse over time and your ability to handle surgery is better now than it will be. So on some level, I might push them a little bit once they're close to 80 to say, what are we waiting for? Because I fear that then you might have another medical condition that then gets in the way and maybe makes surgery not available to you. And then what? Now we're in a chair and the injections don't work anymore. And what do we do now?
Yeah,
and I don't want patients to be in that position.
Completely agree.
So I also think that some patients, their idea of what having arthritis feels like kind of clouds their judgment about replacement too. They think you have to be old, gray-haired, limping around for a long time, having pain over a long period of time. But there are some patients who are quite active and they have an injury that their knee never could really quite recover from. But now it's been the last 6 months that we've tried physical therapy, medications, injections, braces, and they still are not walking well. And I say to them, forget your age. This is about quality of life. And I've tried everything I can, and I don't have anything else to offer you.
I agree, Claudia. A lot of patients come to my office who you can see clearly they need a knee replacement, but they're under the impression they're too young. I'm 65, I'm too young to have a knee replacement. I'm 62, I'm too young to have a knee replacement. And I think that it's our job as physicians to educate patients. And the average age of a knee replacement has gone down from the mid-70s 20 years ago to now, I believe the average age is about 60.5 or 61 years old now.
I thought it was 65. I got to tell my patients otherwise.
The average age of a knee replacement patient. And this topic that you and I are discussing today is only becoming more and more critical because in 2024, there were 1.4 million hip and knee replacements done in the United States. In 2035, that number goes to 4.8 million. In 2040, it goes to 8 million. So this is only something that as time goes by, and hopefully I'll be on a beach in Costa Rica at that time, but certainly is going to become more and more crucial as time goes by.
Yeah, as the population ages, and at the same time, people have been involved in athletics at a high level throughout high school and college, and they've sustained a lot of injuries to their knees, so their knees are often acting older than they are at an age where they didn't expect to be having knee problems. But even people in their 40s and in their 50s, if you are limping, if you've tried a number of conservative treatments like what we've discussed today, and you're taking daily medications, and you're in here now every 2 months begging me for an injection, and you've tried altering, you're no longer a runner, you can only do the bike, you're swimming, but you can't walk around the grocery store without limping. I mean, you're putting a lot more stress then on the opposite foot, the opposite hip, your lower back. Your body is suffering on some level. That weight has to go somewhere. You have a weak link, and your body is just going to redistribute it. So you're paying for it in other ways. And then if all your other joints have now deteriorated, it's not like they're just going to jump back now because you had your knee done.
Yeah,
now
absolutely.
you have all these other issues. Whereas if you had a weak link and you admitted it was a weak link and you tried everything, but your knee was still running your life and it did not give you the quality of life that you need and the activity level that you want for your quality of life, then I think that's a person that should be now considering knee replacement almost no matter what your age is at that point.
Completely agree.
Dr. Lombardi, I will ask you, what is the most advanced age that you've ever done a knee replacement on?
91 years old. And what I tell patients is the number is irrelevant because we all know incredibly young 90-year-olds and we know very old 65-year-olds. So that I really try to eliminate the number in my decision making because if someone is a healthy 80, 85, or 90-year-old individual who's vibrant and leading a wonderful life.
And they want it.
And they come to you, they're coming to you to make their life better.
Better, yeah.
How could you not do a knee replacement for people like that?
Right, and I'll always tell the patient, I'll always say, your knee is a candidate. Your knee is always a candidate, but you have to want to be a candidate, and your internist or your cardiologist need to agree that you are healthy enough for the rigors of surgery, because it is still a rigorous recovery, and there's time under anesthesia, and so there's consequences of that. But sometimes the risk of doing nothing, that has its risks too, of being
Absolutely.
less active, gaining weight. I'll tell patients, knee health is not just about knee health. It is about your heart, your lungs, your bone density, your circulation, your mental health, and your ability to live independently for as long as possible.
Yes.
So it's really a big deal in patients' lives. It's not just your knee.
I completely agree with you, Claudia.
Well, this has been a great discussion.
Are you plugging a book today? I could say to the patient.
No, I have no books.
There's no book that you want me to plug? No? Well, Claudia, that was a wonderful discussion today. Thank you so much for coming in.
Thank you. Yeah, this is a topic near and dear to my heart, and I discuss it every day with patients. It was a pleasure to talk to you about it.
Well, for the audience, we hope it was insightful and informative for you. Make sure you tune in to the OrthoZone for our next episode, where we'll have Dr. Jonathan Sheeran on the podcast to talk about carpal tunnel syndrome. And be sure to follow us on Instagram. Thanks again for tuning in. We'll see you next time.
If you enjoyed today's episode, be sure to subscribe so you never miss an update. Don't forget to share the podcast with others who might find it helpful, and follow us on Facebook and Instagram at Tri-County Orthopedics to stay connected. Thanks again for tuning in, and we'll catch you next time.